welcome to our session today on demystifying what it is to work as a midwife in Atlantic Canada. My name is CJ Blennerhassett and my pronouns are she and they, and I am the CAM president. I'm also a settler of Irish and Scottish descent living in Mi'kma'ki, which is now colonially known as Nova Scotia. I also want to acknowledge that people of African descent have been in Nova Scotia for more than 400 years, in which time African Nova Scotian communities have contributed significantly to the culture, economy, and landscape of Nova Scotia. In my younger years, I also grew up on the lands of the Inuit, Dene, and Métis. Our offices at CAM are situated on the unceded traditional territory of the Kahnawake Nation, part of the Haudenosaunee Confederacy. We recognize sorry, it's small. I had to join from my phone here. We recognize the Kahnawake Nation as the custodians of the lands and waters of Montreal, which has long been a gathering place for diverse First Nations, including Algonquin, Anishinaabe, Atikamekw, and Huron-Wendat. We recognize the historical and continued violence of settler colonialism and are committed to learning and working toward reconciliation through collaborative, bilateral, and reciprocally beneficial relationships with Indigenous people and communities. I know that I'm, of course, speaking to you all today as a settler, but I also know that we're going to talk today about Atlantic midwifery, where there is a really rich and long-standing history of Indigenous midwifery, and acknowledge, of course, that in all provinces in our region here, there have been midwives, Indigenous midwives, as long as there have been humans. Next slide. So I'm really excited you can stay on the other one there. I'm excited to talk to you today about working as a midwife here in the Atlantic provinces. And I have with me some of my really excellent colleagues here today. I have Jessica MacDonald, who's a registered midwife and president of the Association of Nova Scotia Midwives. I have Brittany Stairs, who's a registered midwife and president of the Midwifery Association of New Brunswick. I have Brianna Thompson, chief midwife in Newfoundland and Labrador, as well as past president of the Association of Midwives of Newfoundland and Labrador. And we also have Melissa Roberts, who is PEI's midwifery services lead, which is very exciting. I see now that we have many folks joining, I see that there are lots of our colleagues here in the Atlantic region, which is great. There are lots of people who have been working in this area for a very long time, I see, and also some new faces. So there's lots of knowledge about the area here. Next slide. We're going to, in terms of logistics, we're going to hear a little bit about Atlantic midwifery and kind of the employee model in general. And then we're going to hear from each of the leaders within the Atlantic provinces about the history and the current state of midwifery in each of their areas, as well as some current opportunities. We will then split up into some small groups where you can have discussions if you have individual questions about any of those regions, so each of the 4 provinces. All right, are we ready to dive in? Please feel free to throw some questions in the chat if you have any, and we'll make some space for questions at the end. Oh, also, before we move on, I also just see that we're joined now by my colleague, Alicia Julian Reed, who's a Mi'kmaq midwife. Alicia is working to restore Indigenous midwifery and Indigenous midwifery education in this province. Also, of course, across the country in her role as co-chair of the National Council of Indigenous Midwives. So we'll also have an opportunity to hear from Alicia as well. Welcome. Okay, next slide. So as many of you know, we have a rich history of midwifery in the Atlantic provinces. Of course, as I said, Indigenous midwives have been looking after their communities and catching babies for as long as there have been humans on this land. In particular, I just wanted to highlight in Newfoundland, Mi'kmaq midwife Amelia Jo assisted in more than 490 births in the province between 1941 and 1971. You can certainly ask Brianna and other members of AMNL who I see on the call for more information, as well as checking out the Central Newfoundland Midwifery History Project, which aims to chronicle the legacy of midwifery in that province. There's a really long and rich history of midwifery in that province. Regulated and legislated midwifery is relatively new in the Atlantic region, so perhaps newer than those who are joining us from some other provinces like Ontario or BC. I'll leave it to each of the leaders in the Atlantic regions to discuss that history in terms of their legislation and regulation. And of course, we were joined most recently by PEI, which is very exciting. Each province has a regulatory college, which is often called a council, which midwives need to be registered with in order to practice. So I'm assuming that many of us on the call are registered midwives or have worked as registered midwives across our country in different places. And so, of course, you know this process really well. Each of the provinces has their own regulatory council. And all of the jurisdictions right now, the Atlantic jurisdictions, registrants need to have completed a recognized Canadian midwifery education program. There is not yet, unfortunately, pathways for midwives from outside of Canada to register without first having completed a Canadian education program or a bridging program. In fact, though, many of our midwives in the region were originally educated outside of the country in places like New Zealand or Germany, for example. And as a result, there's a real kind of diversity of midwifery traditions and influences and ways of working here in the Atlantic region. I thought it would be important to highlight in terms of navigating the hiring process, there are some differences in taking on a position within an employment model as opposed to an independent contractor model. So I myself moved from an independent contractor model into an employment model when I moved back here to Nova Scotia, which is my home, from Ontario, where I was educated. And this is partly because in each province, the number of midwives is small at present, although there are lots of opportunities for positions, as you will hear about soon. Hospitals and health authorities, as a result, may often use human resources departments that may be more or less familiar with midwifery. And so a good first step is to contact the association in the province where you are thinking of applying. In all of the 4 provinces, you do need to be a member of the association in order to seek registration with the college and accept an employment offer, etc. And if you're in touch with the association, they can connect you with either a manager or somebody in HR or just kind of whoever is the best point of contact for more information. Sometimes what we see happen is even folks see a job posting which may no longer be available, given that job postings are not posted until they're filled all the time. Sometimes they are, but not always. So jobs may be open even though the posting itself has passed. So all this to say, if you're interested in applying to a position or hearing more information about a position, of course, reach out to your association, as they're a good point of contact and can keep you apprised to opportunities as they come up. I wanted to speak a little bit about some highlights of the employee model. I think there are a lot of benefits, of course. There are benefits and cons of working in all ways as a midwife across our country. But one really great benefit of the employee model in particular, aside from having a pension, which I highly recommend, is the flexibility of the funding mechanisms. So many midwives in the Atlantic region are paid hourly, sometimes salaried. There's some slight differences, which you'll hear a little bit more about, as I said, from the leaders upcoming, or you can also ask in your small groups if there's more specific information you would like. And therefore, there's really great opportunity to have flexibility in terms of what midwives are funded to do. So one of the barriers, as many of you know, in independent contractor models is that it's difficult to develop new funding mechanisms when you have to, liaise with government in order to do that. Here in many of the Atlantic provinces, because we're paid hourly, theoretically, we could be paid hourly by our employer to do anything. There are also mechanisms in some of the provinces for there to be kind of alternate practice arrangements for midwives to work in different call models, different sectors potentially, or to work kind of directly with our interprofessional colleagues. Another thing to highlight is the flexibility of the call model. So of course, depending on the strength of the team, how many people you have, kind of what your catchment area is, all the same things we take into consideration in an independent contractor model. There is the potential for there to be flexibility in terms of the call model because there's flexibility in terms of how you take vacation, for example. And yes, we are paid to take vacation here. In all places, you have the option, depending again on the strength of the team and how well resourced they are at the time, to also support home and hospital birth. In some areas of the Atlantic region, there are second attendants. So those could be nurses, or sometimes they're other health professionals in other roles who work with midwives to, improve our human resources and attend home births with midwives. So that's exciting. Also, in many places, in terms of interprofessional collaboration, there is, unique relationships with other healthcare professionals, but in particular with nursing. There's actually some research that's come out of the Atlantic region about the relationship and the collaboration between midwives and nurses, given our clients in hospital have the support, in most places, not all, of a nurse throughout the duration of their admission. We also, utilize the support of nurses for things like triage, for backups in hospital. They function in that kind of second midwife role. That's true in all 4 places. And that collaboration really allows us to work closely with nursing to learn from them. They can learn from us, and we can really have an impact in a lot of places on the culture of birth at the various hospitals that we work in, which is great. Next slide. Thank you. Okay, we will have an opportunity for questions at the end, certainly, but like I said, throw them in the chat. We'll be monitoring that closely. And now we'll hear from Melissa.
Hello, everyone. I'm Melissa Roberts. I've been a registered midwife for just over 10 years now, and just started the position here as midwifery services lead in August of this year. CJ stole my line. Midwives have been in PEI for as long as people have been having babies, and that's the truth of it, and especially when we look at Indigenous midwifery. Joyce, who's the president of the PEI Midwives Association, who I noticed is on the call, actually drove me around the island in March and even showed me an existing birth house that's still standing, which has a rich history of birth on the island. Unfortunately and fortunately, PEI was last province or territory to implement midwifery, regulated midwifery, and that came about in October of 2022. So brand new, but people have been asking for midwifery services for a very long time. And in 2019, there was a steering committee struck that had a multidisciplinary representation. I was on there as the program development lead, along with Gisela Becker, who I think is also on the call here as the chief midwifery consultant, to help build regulations and bring midwifery to the province. So we worked through a pandemic and we worked through Hurricane Fiona, and we eventually got to regulations, as I said, in October of 2022. The current state of midwifery here is very much development and implementation. I am the sole midwife, registered midwife on PEI right now, and am putting in a lot of effort to do outreach, learn the system as it currently exists, and find, great avenues for implementing midwifery services. But I will say that I would love to have some midwifery friends with me on the island. We have recruited 2 of our positions that we have posted. So I'll have a midwife joining me in December and another one who will come in July. But that does create an opportunity of, for midwives who are interested in coming to PEI to be part of a program from the build up. While a lot of work has already been done, we're really starting to, sort of display our role and our scope of practice here in the province, and it is an exciting opportunity. In terms of the call model, that is to be determined, but it'll obviously change as more midwives are onboarded with a sole focus of sustainability. That's one of the things that a lot of people transition to the employee model for, is a bit of a slower pace of life and a more sustainable midwifery model. We did build into our regulations choice of birthplace, and even though we haven't onboarded any clients yet, we can already hear lots of excitement around the island for people having choice of birthplace. CJ sort of already mentioned, as part of being an employee, there's lots of benefits. There is a pension, there's sick time, there's overtime, there's callback time, anything that you would sort of see being an employee under any other umbrella. And health benefits. There's lots of exciting things that are included in there. Also mentioned was interprofessional collaboration, especially with the nurses. So we did build into the program here that nurses would be our second birth attendants in hospital, for instance, and looking at avenues for them to be second birth attendants in the community. And it does allow for great teamwork and collaboration and for understanding scope of practice. Our nurses here are quite excited to learn from the midwives, and we can learn a great deal from the care that they provide as well. What I'm noticing here on the island, and what I'm also developing, is other avenues of interprofessional collaboration. From learning the healthcare system, we see that there's lots of areas where midwives can help because it is within our scope of practice. And there's actually a really big appetite here for midwives helping the system. So, for instance, there's a nurse practitioner who's running an unaffiliated clinic, who I'm going to meet later today, actually, to start talking about how midwives can help at that clinic. There's a sexual health options and reproductive services, who is mostly run by a nurse practitioner, but also by a family physician. And again, in conversations with them, there's lots of expressive interest for midwives to help out in their clinic as well. So there is some really great opportunities here for collaboration with lots of other professionals. Annie, I'm not sure if you're in control of the slides, but I'll get you to hop me over to the next one. We actually developed, this table was actually pulled off of a document that was sort of requested from the island for education for physicians about midwifery scope of practice. But I thought it was a good overview to sort of outline things that are included in our regulations for midwifery. There's a lot of words on that slide, but what we really aimed for here was full scope midwifery practice. And to me, especially, I think some of the exciting things that I see on here are an ability to prescribe narcotics in labor, an ability to order oxytocin for induction and augmentation of labor. Phototherapy in hospital is included there as well, along with contraception, including IUD insertion. While I spent almost all my career in Central Alberta and thoroughly loved my time there, it was some of the frustrations that I seemed to need to consult for these things. So I'm a very big fan of midwives practicing to their full scope. So I was very excited that this was included in the regulations here. But I'll turn us over to the next province, and happy to accept some questions when we sort of do our breakout rooms.
Hi everyone, I guess I'm up. So my name is Brianna Thompson, and my pronouns are she and her. And as CJ mentioned, I am the Provincial Chief Midwife in Newfoundland and Labrador with the Department of Health and Community Services. Currently on maternity leave, and also the past president of the AMNL. It's so great to see how many people are interested in midwifery in Atlantic Canada. So to focus on Newfoundland and Labrador, next slide, Annie. CJ also touched a lot on our history, and I won't go too far into it, but there is such a rich history in this province, where you're still meeting people all the time who are talking about how they were born into the hands of midwives, or their parents were, or their grandparents were, or grandmother was a midwife. And pre-legislation midwives worked well beyond the 1950s and even up until just under a decade ago in some parts of Labrador. So very rich history. Everyone has a story about a midwife here. Midwives regulations came into force in 2016 in Newfoundland and Labrador under the Health Professions Act. And our registration is a little unique. We have both a council and a college. So the Newfoundland and Labrador Council of Health Professionals, the NLCHP, they govern the regulation of midwifery in registration, professional standards, quality assurance, complaints, and discipline. And then the CMNL, the College of Midwives Newfoundland and Labrador, work with the NLCHP to serve and protect public interest. And it's our college who defines our scope of midwifery practice, our standards of care, code of ethics, continuing competencies, and have approval over any midwifery education program. So when midwives come here to work, you are registered with both. It's one process, it's one portal, but you are a member of these two bodies. Next slide. In terms of scope of practice, Newfoundland Labrador is what most places would consider full scope midwifery, and a lot of what Melissa was saying rings true here too. There's maybe a little more room to wiggle here than there are other places where you're still advocating for certain pieces. But the core competencies that are listed there, this is straight out of a document from our college called Core and Advanced Competencies for Registered Midwives in NL. These core competencies are what's expected of all entry-level midwives. And includes epidural monitoring, farm augmentation of labor, induction of labor for post dates, prescribing contraceptives, and providing well woman care after 6 weeks postpartum and to healthy individuals in general. And then we have our advanced competencies. So these are things that midwives can apply for with proof of clinical skill and competency in that respective area. So things like first surgical assist, IUD insertion, vacuum extraction, bedside ultrasounds, manual removal of placenta in non-urgent situations, and more. So this list isn't exhaustive, but it can all be found on the college website. Oh, that one got wonky. So following regulations in 2016, the first midwifery program was launched in Gander in central Newfoundland in 2019. So these midwives are employees of the Newfoundland and Labrador Health Services, NLHS, which is our provincial health authority, and it's a team of 4. The office and clinic are in the Bell Place Community Health Center, and they attend births in the community as well as the hospital, which is the James Peyton Memorial Regional Health Center. And they share caseload and call as a team of 4, practice full scope, and are supported by nursing and hospital who act as backup for births. And there's just some pictures of the midwifery team there. Next slide. In terms of compensation, as employees, you've heard of some of the benefits, things like having benefits and pensions, sick leave, parental leaves, things like that. It is like an employee of any type of service, but is unique for employee models. In terms of the salary, our hours are based on a 37.5 hour work week. But that is actually, when claiming it, so it's 150 hours in a 4-week period to kind of reflect the flexibility that midwives need to have in their schedule. That it's not always a 37.5 hour work week. Some weeks are bigger, some weeks are smaller. So those 4-week blocks, a base salary would include 150 hours in that 4-week span. We are unionized with NAPE HP, who determines what the salary is. So midwives are the CG44 pay scale. And I've listed there what those pays would be like. So a midwife who is newly graduated, no experience, would begin at step 1. That's at $43.36 per hour, or $84,500 per year. While a midwife with 4 years of experience has reached the top level of pay here, and would be at that upper level of $51.16 per hour, or just under $100,000 a year. And these rates are receiving 2% increases annually with our union. So that's your base pay. That's just the hours that you work. In addition to those hours, obviously we know midwives do a lot beyond those regular hours. So you also receive standby pay and callback overtime pay. So standby pay, it doesn't look like much, but it does add up when you are on call a lot. It is something that you're paid for 8-hour coverage calls or 12-hour coverage calls. So when you are in the office all day, but then you're on call until the next morning, you are receiving some standby pay after, say, 4 p.m. until 8 a.m. the next morning when someone else maybe comes on. In terms of what callback pay is, if you've never worked in an employee model, callback is, say it's the weekend, you've been paged out, you go do an assessment, it takes about an hour, and then you're back home. But this is an outside of hours weekend call that, because you're on call, you are the midwife responsible. So you'll work for an hour, but you're paid for 3 minimum. If you work beyond 3, you get paid for whatever you worked, but it is also paid at time and a half. So working for 1 hour on the weekend is worth 3 hours at time and a half. So obviously that base salary does bump up quite a bit when you are a busy on-call midwife working lots of hours beyond the normal business week. Next. So many people are probably wondering, like, where's the province going? It's still early. We are definitely growing. So Health Accord NL's Call to Action 33. Health Accord NL was a 10-year health transformation plan that was published in 2022. They called for new or enhanced programs in midwifery. So that was a call to action in our province for how we're going to reimagine our system. Since then, Budget 2023-24 approved a 5-year plan and the budget to go with it to achieve province-wide access to midwifery services. So this basically means we will be increasing from our original 4 positions in Gander to 20 positions by 2027, and we'll have midwifery services available in all 5 health zones. So Gander started in 2019, that's the central region. Labrador, specifically Goose Bay, is planning for a team of 3 midwives coming in 2024. Eastern Rural Zone, specifically Carbonear, is planning for a team of 4 midwives coming 2024. And then following will be Eastern Urban Zone, which is St. John's, and the Western Zone, which would be Corner Brook, by 2027. Implementation work has not started in those last 2 zones yet, but is underway in Labrador and Eastern Rural. The province is also looking towards, the future in terms of the growth and sustainability of midwifery. So the provincial government, the Department of Health and Community Services, is currently funding and leading an Atlantic Midwifery Education Program feasibility study. So Gisela Becker, who is here, is the researcher, and these findings hopefully will be disseminated in 2024. But this is a really important first step towards establishing a plan for midwifery education here in Atlantic Canada. Next slide. In addition to those programs I mentioned, there's also an amazing program happening in Labrador, the Innu Midwifery Program. It's a community-based Innu-led education program that launched in April of this year and actually had students beginning in September of this year. So the program aims to reintroduce midwifery to Sheshatshiu and Natwishish, which you can see on the map there, drawing on Innu elders' knowledge of Innu birthing practices to support the training of Innu midwives using culturally specific, hands-on, and individually paced learning approach. So restoring midwifery to these communities will result in Innu babies being born into Innu hands on Innu lands, which is just so exciting. And this practice will be a really important partner to the midwives that will be established in Goose Bay, since Sheshatshiu is only 40 minutes away. So that's a really exciting opportunity for partnership. For more information about this program, if you're interested, you can contact Gisela Becker, who's on here today. So she's the midwifery implementation coordinator for this program. And you can also follow their journey on Facebook. If you just look up Innu Midwifery Program, the students are keeping us updated. Next slide. In terms of current opportunities, I've already alluded to a few, but there are a number given the plan and pace of growth that we are hoping for in the next several years. Central Zone, Gander, the practice that was established in 2019, is still looking for 1 full-time midwife. So that is an active posting that you can find in Central. Labrador Grenfell Zone, Goose Bay is looking for their 3 midwives to start that program in 2024. Eastern Rural, Carbonear, they've just started already in terms of posting. So they did post 1 midwife implementation coordinator position, and 3 more positions will be posted soon. And then in terms of other opportunities, there's so much opportunity to gain leadership experience in Newfoundland and Labrador through the AMNL executive, CMNL executive, and through representing midwives on a number of interprofessional committees and working groups. So it's a really province-wide, really good opportunity for some personal development and leadership experience and growth. Next slide. Incentives. So, you know, things that, when you make a plan to recruit somebody with midwives, you have to sweeten the pot a little bit. So there's definitely some incentives going on right now to attract midwives to Newfoundland and Labrador. The most notable one is the come home incentive. So this is something that we only have guaranteed until the end of this fiscal year. Hopefully it will be renewed, but it is targeting everyone really, but midwives with ties to Newfoundland and Labrador. So whether you have a family history there, or you've lived there, you studied there, it's defined in many ways, but they're eligible, if taking a position in Newfoundland and Labrador, eligible for $50,000 with a 3-year service commitment. And midwives with no ties to Newfoundland and Labrador at all are still going to receive $25,000 with a 3-year service commitment. In addition to that, we have signing bonuses for midwives. So for difficult to fill positions, you're eligible, and they're tiered to address geographic considerations. So signing bonuses, you know, higher in Labrador than say the Avalon, like St. John. So for Goose Bay, it's $8,000 for a 1-year service commitment, or $16,000 for a 2-year if folks want to do that. We're also eligible for health professional bursaries for difficult to fill positions. The values are there again with return and service commitment. Midwives in Labrador receive Labrador benefits in addition. There's a little bit of travel allowance to cover costs of traveling outside Labrador, and there's an incremental salary benefit and additional leave available whenever you experience travel disruptions. And then all midwives are also eligible for relocation assistance. So it's a good time to come to work in Newfoundland and Labrador. Next slide. So that's it. If you have any more questions, I know we're doing breakout rooms, but if you can't stay, feel free to reach out to me, brianna.thompson@gmail.com. That's my personal right now. AMNL, you can follow us on Instagram, Facebook. Our website is there. There's also the president's email. The College of Midwives Newfoundland and Labrador website's really great. There's lots of good information in terms of what is included in the way that we work, and the Newfoundland Labrador Council of Health Professionals website offers a little bit of information, but CMNL definitely has more. So that is it.
Thanks, Brianna. My name is Brittany Stairs. I use she, her pronouns. I'm the president of the New Brunswick Midwives Association, as well as a registered midwife working in Fredericton, New Brunswick. Start with a little bit of a history. And it was in the early 2010s that midwifery became regulated in New Brunswick. And then in 2016, a demonstration site in Fredericton was announced, and it would be part of the local health authority. There were an initial 4 positions that were funded, and in the fall of 2017, midwives began working with clients out of a community clinic. So the picture here is of our first 3 midwives that worked with some of the first babies that were born in that fall and early winter of 2017, 2018. So since 2017, our midwives have served more than 500 families in the Fredericton region. We've made a lot of inroads in strengthening relationships with our hospital staff. There's demand for midwifery services across New Brunswick, and a lot of opportunity for growth of the profession, both in New Brunswick and across the province. As part of being a demonstration site or a pilot project, the Department of Health ordered an external evaluation of the program. That was complete. Oh, if you just go, yeah. That was completed in the spring of 2022, and the full report hasn't actually been released yet, but we did get a copy of the summary evaluation, which was overwhelmingly positive. It calls for strengthening of the current midwifery site in Fredericton, expansion across the province, prioritizing education and training of new midwives, and updating the Midwifery Act in order to help midwives work to their full potential. And then of course, the demonstration or the report, the evaluation also demonstrates the midwifery program has had good health outcomes as well as very, very high client satisfaction. So what we're doing as an association, this report's been out for more than a year and a half now, or it's been done for more than a year and a half. It hasn't been made publicly available. We are currently working with a government relations firm with CAM in order to be able to advocate for the expansion and strengthening of midwifery across New Brunswick. So although there hasn't necessarily been a lot of changes since 2017, there is definitely a sense of things are about to change, which is really exciting. So like I said, in Fredericton or in New Brunswick, currently there's just the one midwifery center. We have a non-clinical manager who manages one site as well. Also, so she manages our site and another site. And then we also have one admin. So those are like, we don't pay overhead costs. The clinic is provided for us. Our admin is provided for us. Our manager is provided for us, all of that. In terms of current opportunities, coming up, we have a permanent part-time position. So it's about, I would say on average, about 20 hours a week with the opportunity for more hours. So that one's currently available anytime. There's an upcoming temporary 18-month full-time position. And then there are two casual positions. And when I say casual, I kind of imagine them very similar to locums positions. So in the past, when we've had midwives fill a casual position, they've come for a certain amount of time, have left and come back multiple times. Can I get the next slide, please? So the ins and outs of being a midwife in New Brunswick. So I did just do a little graph. This is our home birth numbers versus our hospital birth numbers. So we have about 1/3 home birth rate and a 2/3 hospital birth rate since we started. So like I said, we're a community-based clinic located in Fredericton. We're employed by Horizon Health Network. We have a non-clinical manager, full admin on site. So in terms of permanent positions, we have 3 full-time positions and 2 part-time positions. And like I said already, there's the temporary full-time and the permanent part-time that's available. In terms of our call and clinic model, 2 midwives are always on call to cover the 24/7 service. We've worked in different models, so we always are sharing call, but we've worked on 2 different teams. We've worked as a larger team. For instance, I was in the past almost doing primary care where I have my own very small caseload, and then there's another team that has a larger caseload. So there's been lots of flexibility. I think it just depends on the midwives that we have and how we're working at the time. And then in terms of some other opportunities that we have, because we are employed with Horizon Health, we have had the opportunity to be a part of a lot of different committees, and we get paid for that time. So for instance, this morning, I was just asked if one of the midwives wanted to be a part of recreating our prenatal healthcare records. I'm on maternal and newborn working groups. We're on breastfeeding working groups. So there's lots of different opportunities to get involved in maternal and child healthcare here in New Brunswick, and you get paid for your time because it's part of your work with Horizon Health. In terms of our funding, like I said, all those overhead costs are paid by our employer. So our clinic space, our admin space, our home birth equipment, our assessment supplies, everything is included for us. I saw a question in terms of phone. We have work phones, and our insurance is paid. Our insurance is with our association, but it's paid for by our employer. Very similar to what Brianna went through with Newfoundland, we have hourly pay as well. 37.5 hours is what's considered full-time. Anything above that in a given week is paid at 1.5 times your hourly rate. And if you work more than 150 hours within a set 4-week rate, then you also get overtime for that you can either be paid out or you can bank for vacation or whatever else. Or if you have like a week where you just don't want to work very much or you don't have as much to do, then that kind of sits in a bank that you can pull from. If you get called in when you're off call, so you're not set to be on call, but you get called in for clinical work, then you get paid at a double rate. And then there's a small on-call pay that really honestly does add up quite a bit. And then there's a small top up for night and weekend work as well. I didn't put the hourly ranges down, but they range from $38 to $56. So when you start, depending on your years of experience, you start at the lower end, and then every year you go up until you reach the top end. And then there's, of course, like the cost of living inflation that's added every year depending on your contract. And then in terms of benefits, we are part of a union as well. It's not a midwifery specific union, but we are part of a union. We get continuing education funding. So currently there's no set limit to how much we are able to use every year. It's just at our manager's discretion, but we've been very fortunate. The continuing education that I've wanted to pursue, our manager has always approved. So that's been really nice. So I get paid from both. It is funded, and then my time doing it, I also get paid for. Travel expenses and the time that you spend traveling is paid for. And again, similar to other places, stat pay. Our vacation here, I think, starts at 3 weeks, and then every year you get a little bit added to that. A lot of us can take more time than that because when you work overtime, you can bank that. And then, admin support, pension, like CJ mentioned, health and dental, long-term disability, all of that is part of our benefit package. And then in terms of place of birth, I did want to mention, again, of course, home birth and hospital birth. One worry I had coming, because I trained in BC, I'm from New Brunswick, but I trained in BC. And so when I was coming to New Brunswick, I was a little bit worried about kind of being told, what I could and could not offer for home births. We haven't had any limitation imposed on us for home births, not even during COVID. We do follow community standards and practice standards. And then, of course, there's the expectation that when clients are following standards outside of, community recommendations that we're thoroughly documenting, but we've been able to offer choice-based or choice of birthplace, depending on client preference and shared decision-making. We don't currently have a second attendant program, but there has been foundation for it created in the past, both with our council as well as with our employer. There's just different reasons it didn't go ahead, but that is possible. And then in terms of who's our backup, so at home births, it's the second midwife on call, and then at hospital births, we do work with our nurses, and they are the people who attend for our second attendants. And then I just wanted to mention too that at our clinic, we have been really fortunate that we actually do all of our own lab, or we collect all of our own labs, and we're able to offer vaccines here as well. So routine vaccines are offered at our clinic, which is really nice. And then next slide, I think, please. So scope of practice. I mean, our scope of practice is very similar to elsewhere. I wouldn't consider us necessarily working full scope in the same way that PEI and Newfoundland had mentioned. Though those in terms of like ordering oxytocin or doing a post-dates induction, epidural monitoring, those are all advanced competencies, but there's not currently a mechanism at our hospital in place. That's not to say that it won't be in the future, but that's just where we are now, but they are part of our advanced competencies. I did want to mention, just in terms of expectations for council registration, there's the narcotics and benzos course is an expectation. And then within 1 year of registration, STI management and hormonal contraceptives starting this year is going to be required. So that will be part of our scope, which is new. That being said, again, one of the benefits of being an employee here is that our employer will pay for us to do these courses. So it's part of registration, but because currently our council is giving us a year from the date of original registration, that means that you can come, you can get the employer to pay for the course, and then you'll have that for your next year. And then advanced competencies, I kind of already mentioned, but again, surgical first assist, there's more that I didn't mention here as well, but those are on our regulations page, or those are on our as part of our regulations, which can be found both on our association's website, which is nbmidwives.ca, as well as our council's website. And then one of the recommendations of our evaluation was actually to open up the Midwifery Act to further increase our scope of practice. So even though we aren't necessarily working full scope, I think that there's a lot of hope for the future, especially because the evaluation was government or requested by the Department of Health. It's data that's specific to New Brunswick. That one of the recommendations from this evaluation is to open up our act to be able to add more to it. And we've been creating a list for a while of things we'd like to see. For instance, we have been working with our council with the possibility or towards the aim of being able to help out at maybe like a sexual and reproductive health care clinic. And that's something that we're working to try to get the foundation based for. Or, you know, there's been talk at our hospital of babies right now who aren't attached to a care provider being rounded on by family doctors. And we've been like, oh, well, maybe we would be able to also be part of that group that rounds on healthy babies, which actually would be able to happen within our scope as it is currently. But there's definitely ways that we're talking about how we can be of the most use to the healthcare system in New Brunswick. So there's a lot of really exciting opportunities there. And that's one of our midwives actually at a home birth recently. And then I think that's everything. I do have one more slide. I just thought I'd show some pictures of our clinic. These are our midwives who are currently with us, Ursula, Jasmine, myself, and Ashley. And then that's our clinic space. We always refer to it as the Red Church. Everyone knows what we're talking about and where it is. And then, yeah, our lovely clinic rooms and office space. And I'm happy to answer any questions at the breakout rooms. Thank you.
Thanks,
Brittany. I don't know if you. Oh, sorry, CJ.
Yeah, thanks, Annie. There is just one question that I'll get you to answer before we move on from Simone in the chat. Wondering, so in Fredericton, if your client gets an epidural, are you required to transfer care and leave?
Right, exactly. Sorry, I did have that as my notes, but then I skipped over them. That's a great question. No. So in terms of epidural, induction of labor, oxytocin augment, they're all just consults. They remain in our care. Well, induction of labor, I should say, like typically they get the induction going, care is transferred for that. But once they are in active labor or even a little bit before that, they come back into our care. So even though I'm not able to order any of those things, I still remain the primary care provider throughout. So it's a pretty seamless process, really.
Thanks, Brittany. It's one of the benefits of being hospital staff in many places or health authority staff. You have close relationships with those providers.
Yeah, and I will say in terms of not running an epidural and oxytocin, as soon as there's oxytocin and nurses in the room, because they're not necessarily always in the room, they can be, but they aren't necessarily. I actually often use that opportunity to go sleep. If a client has an epidural and they're sleeping, then I go get some sleep too, especially since we tend to be on call for longer than 24 hours at a time. So I think there is the big benefit of like increasing those relationships, but also just making it a little bit more sustainable for yourself as well.
Definitely. Thank you. Jessica, you're up.
Hi, everyone. My name is Jessica Thorpe, and I'm the president of the Association of Nova Scotia Midwives. My pronouns are she, her, and I'm also a registered midwife working in Halifax, Nova Scotia. So I think there's been lots of chatter about the history in the Atlantic region as a whole, and I know our colleague Alicia Julian Reid is here who can speak to the history of Indigenous midwifery in Mi'kma'ki and all of the work that's being done to restore Indigenous midwifery in the province. But I will speak to midwifery since it's been regulated in the province since 2009. That was through the Midwifery Act, and the profession is currently regulated by the Midwifery Regulatory Council of Nova Scotia, whose mandate is to serve and protect public interest by regulating the practice of midwifery. Midwives in Nova Scotia are working as employees of either the IWK Health Centre or the Nova Scotia Health Authority. So currently we have 3 practice sites across the province. We have 4 positions at the Highland Community Midwives, which serve Antigonish, Cape Breton area, 4 midwives at the South Shore Community Midwives on the South Shore or in Lunenburg, Bridgewater area, if those areas are familiar to you, and 9 midwives, 8 full-time and 1 casual position at the IWK Community Midwives, which services Halifax Regional Municipality. In this map is from 2021, but it was similar in our 2022 data that midwives accounted for 5% of the births happening in the province, with 16 midwives working during that time. And our provincial home birth rate, which obviously fluctuates by practice site and by year, was 17.8% the last time we collected that data. And so for those of you that may or may not be familiar with Nova Scotia, I've just put a little heart where those practice sites are located. There has been recommendations made over the past decade or so to expand midwifery services, because right now there is a huge demand for the Wolfville area. I'm not sure if you can see my mouse, and the Truro area, as well as the expansion into Northern Cape Breton. That hasn't happened quite yet, but it's certainly something we'd like to see with all of this growth that's happening in the Atlantic region, something we're hoping that we can move towards. So currently for job opportunities, we are hiring in the province at different practice sites for permanent and temporary positions. As mentioned, please reach out to us as an association if you're interested in working in Nova Scotia. And I know we'll have more time in the breakout groups to chat about that, because even if there's positions that aren't currently posted, we are aware of some positions that will be coming up in the coming months. And all, a lot of these positions tend to be parental leaves at this time, but of the midwives that have been hired to temporary positions in the last number of years, they have had opportunities to make those positions permanent or move into a permanent position. So I don't want the temporary part to draw you away from applying to join us in this province. Our compensation is based on a 37.5-hour work week, or 75 hours biweekly. And you're paid for the hours that you're working. So if you're at a 20-hour labor, then all those 20 hours are going on your paycheck. And as you know, because of the nature of our job, I'm sure you can understand that oftentimes the number of hours worked in a given week are above 37.5, and sometimes you have a slow week when you are working less than that number of hours in the week. And so there is an opportunity to kind of bank overtime hours and use those on a week that may be a bit more slow, or there's always other work that can be done to fill those hours. Our hourly wage right now ranges between $44 to $55 an hour, which calculates about 80,000 to 107,000 annually. And this does not account for additional standby, on-call pay, which I believe it was Brianna that explained, overtime pay, or pay during holidays. So our standby rate in Nova Scotia is $13.50 per 8 hours of on-call time, which would be about 40 hours for every 24 hours that you're on call. And when we're on call, if we're called out for an assessment and the assessment takes 2 hours, we're automatically paid for at least 4 hours of call time. So those assessments that get you out of bed in the middle of the night do come with a little bit of an extra incentive if they're less than 4 hours of your time. And that's straight time, not overtime. Holidays that you work are paid at time and a half, as well as 7.5 hours that you can bank to use as a vacation day, since you didn't get to have that paid day off. If you're not scheduled to work a holiday, then you are receiving pay for that day, standard pay. For vacation, depending on how long you've been practicing, is usually around 4 to 6, starts at 4 weeks and can go up to 6 weeks, but there is an ability, like I said, to bank those overtime hours and use that as time in lieu as you need. And our benefits and pension are offered by our employer through the Health Association of Nova Scotia and through the Nova Scotia Health Employees Pension Plan. And right now it's a approximately 40% employee contribution with every paycheck towards your pension. And then it's being topped up by your employer at a 60% rate. So our scope of practice is, I guess, what you would consider full scope. And I think when we get asked this question, I think of it as kind of the Ontario model, where is it a transfer of care for an epidural? Is it a transfer of care for oxytocin? So we are managing epidurals and oxytocin for induction in Nova Scotia. We do require a consultation to our obstetric colleagues for induction if it's not for a post-dates pregnancy, but we can order induction for a post-dates pregnancy, and we can order augmentation of labor. Typically what happens just based on resources is that if we are ordering an induction, then the OB or the OB resident starts the induction and then transfers care back to the midwifery team once that client is active, and that's the time that we would go into the hospital. We are prescribing contraceptives in Nova Scotia, and recently it's been added that those who complete additional training can offer IUD insertion. We prescribe narcotics in the hospital setting, and our ability to do this is conditional upon completing the opioid and benzodiazepine safe prescribing for midwives course on registration with our council. And midwives in the province maintain competencies in CPR, NRP, emergency skills, and fetal health surveillance. Recently, our midwifery council here has approved an alternative practice arrangement policy, which there's been some creative ideas floating around as to how midwives can use this new policy and work in different ways, whether that's a hospitalist midwife or midwives working in communities that aren't currently served by the current practice sites. This is all new and exciting, and just shows that, you know, there's lots of, I think, ways that midwives could be working in Nova Scotia that in room for growth. There's also lots of opportunities for interprofessional collaboration. So I took this little headline from CBC, near the water, in the water. Halifax mom pushes for IWK water birth for her son. This wasn't the baby, but I just love this photo of a home water birth that happened with one of our teams. But when a few years ago, we did have our first hospital water birth, and what that led to, it was kind of pushed by one client specifically, but what that has led to is the ability for us to facilitate more hospital water births for any clients that wish to have them, and education sessions that have been facilitated by midwives to the nursing team, family physicians, and obstetricians, so that more providers on our birthing unit will be ideally supportive of water birth and open to providing water birth to their own clients. There's been also a push to create some low-risk birth spaces within our birthing units. So the Highland Community Midwives has a beautiful room off of their labor and delivery unit that was set up a few years ago to create kind of a home birth setting within the hospital. And the group at the IWK has been looking at creating kind of something similar within the birthing unit there. We do have a second attendant program for home births that utilizes our registered nurses. So nurses that work in labor and delivery and have that experience are able to apply to be second attendants and be on call for us for home birth, which is great because it's a nice way for us to, you know, work a bit more closely with nurses, but also for those nurses that then, you know, go back to the hospital and are able to say, yeah, I was at this beautiful home birth the other day with the midwives, and they get to see kind of that other side of our work outside of the hospital. And we also work closely with nurses in hospital providing continuous labor support. So for every client that we have in labor, they're also assigned a nurse, which I think just provides a lot of opportunity for nurses to see how midwives provide care, and we're not calling them in those emergency situations. Nurses are our backups within hospital for birth and are usually, you know, working quite closely with us. And these are some of the faces of midwives, a few past, most present, that are working in this province, that if you want to come join us, we would love to have you. We had to get creative on the bottom photo during the pandemic of instead of having group photos, but I love that one. I will just highlight the Highland Community Midwives in the right corner, just moved into a beautiful new clinic space. I should really have added some photos of their new space in these slides to show you, but yeah, we're really excited for them.
Thank you, Jessica. There was one question in the chat from Simone. Does it seem like there is any chance for midwives in Nova Scotia to be including medical abortion in scope? Actually, I'm curious about this across all of the Maritimes, but maybe you can speak to Nova Scotia.
Yeah, we this actually just came up in a meeting this week, that there seems to be more discussion happening around it. So it would what we're hoping to do is, as an association, kind of put forward a proposal to our regulatory council to open this up a little bit, but there's support through, there's a provincial group called the Reproductive Care Program of Nova Scotia that's working to kind of make abortion care more accessible throughout the province. And so it would likely be a collaboration with some of the physicians that work with that team to make this happen. So it's in the works, but it hasn't happened quite yet, to answer your question.
Thank you, Jessica. And lastly, before we move into our small groups, I would love to hear from Alicia Julian Reed.
Thank you. You always have to like take a second, find your mute button, right? Start talking. You can I'll lip sync for everyone. So my name is Alicia Julian Reed. I'm the co-chair, one of the co-chairs with Brenda Ipu of the National Council of Indigenous Midwives. I think I'm wearing my Mi'kmaq midwife hat today. I work with Nova Scotia Native Women's Association in partnership with Dejigamic. So Dejigamic is a Mi'kmaq word, and it has to do with health and wellness. And it's the newly formed Mi'kmaq Health Authority here in Nova Scotia. Very similar to the British Columbia First Nations Health Authority. And while building capacity, Dejigamic has partnered with Nova Scotia Native Women Association for the last 2 years to do community engagement. It's very unique for those of you who are listening from different parts of the country. Mi'kmaq territory known as Nova Scotia, which also includes New Brunswick and PEI and parts of Newfoundland, but I'll be referring to Nova Scotia specifically, is made up of 13 Mi'kmaq communities, and which is very unique, right? Because it's one nation. So in some ways, our engagement process and recommendation for the province can be more straightforward because it's a nation-to-nation relationship. It's a lot of ambitious work happening, and we are excited to. We're at a stage where with a lot of national work happening around anti-Indigenous racism, there were federal funds available, like seed funds, right? Just kind of an initial amount to explore what the Mi'kmaq communities are asking for. And what came up as a priority is, like most of the country, is to have birth and sexual reproductive care as close to home as possible. And a big part of that was initiated through a Mi'kmaq family who wanted to birth on the land. And the weather was permitting. They had a great relationship with the midwives in Antigonish, who really helped facilitate that alongside the health center specific to that community. So that community is Buttingate First Nation, and we mention it because through our engagement, we came to realize that they are the most ready. Community readiness is a big part of promoting midwifery, and with their community and leadership already supporting birth within the community and making that happen, they now are going to be the first site to have a birth center built. We're currently working with an architecture group that has been building the Resiliency Center. So the Resiliency Center will be a space that's owned or being regulated by Nova Scotia Native Women's Association, and that's being built in Millbrook First Nation, which is about an hour from Halifax. And in that space, it's like it's pretty amazing. Like, they talk about if there was an apocalypse, that they would be able to sustain itself based on how it's been engineered to be green and self-sustaining for at least a month on its own. So that type of innovation and building infrastructure is pretty exciting. So the same folks who have been working on finishing the resiliency center are the folks that will be working on the birth center in Buttengate. So they're just at the initial stages of community engagement to really understand what the community wants. So when they're putting those blueprints together, it's really thoughtful because it's coming from the people first, and they have multiple projects of this format throughout the province, including the Halifax Friendship Center. So our capital city here in Nova Scotia has a friendship center, and they will be building a new building. They have it, the funding, and they'll be breaking ground. I can't tell you exactly when, but a part of their build includes a birthing suite. So that's pretty exciting. So basically what's happening is that there's a huge priority to have midwifery take place, and specifically Indigenous midwifery. And as we know, education is the #1 priority to move all of this work forward. So currently we are seeking partnership to co-develop with an institution, an education program that is community-led, and this is just a really strong opportunity for folks to make meaningful steps towards truth and reconciliation. And so part of those possibilities, as we know, we can name all the universities in Nova Scotia, but we'll definitely be speaking to Dalhousie, Cape Breton University, and St. FX, as well as Mount St. Vincent and Acadia. Everyone will be invited at that level. And what's neat is that Dalhousie is moving forward with making one Indigenous health professions, including dentistry and medicine. And so we've been having initial conversations to include midwifery at the beginning. And part of this whole the entirety of it is really based on a nation-to-nation relationship that exists in Nova Scotia, because we do have established treaties that continue to be respected and looked at and revisited. So with building capacity, like we're looking to all of the examples across the country. We know that the legislation doesn't include an exemption clause at this time, but legislation and is being visited as well, and research is being done to figure out if we need to have our own exemption clause, or if some of the agreements between the province and Dudjikamic may actually make allowance for this work to be done without changing the legislation. But all of that is being visited. The other piece is that there's a real desire to work together, right? There's an understanding that nation sovereignty, as well as self-governance, all of those aspects, and safety in keeping our people safe, because we know that all of the clear data show that unfortunately Indigenous families are not kept safe within the current system. So we want to prioritize that. And I know that the province in their, they're strategizing for health and advancements that they're making, want to do the same. So we're in partnership with Jessica Thorpe and others, and making sure that we hear one another. We do this in a good way. And it's the beginning stages. I think that we were quite ambitious in hoping to be able to hire midwives in Buttengate First Nations sooner, but unfortunately, like anything, it takes time, and we're ironing out some things. But just to be meeting with the architecture group recently just sparked such excitement, because you're seeing like, okay, this is happening. And it's Six Nations did it. They built their birth center first, and then the midwives came afterwards, right? Like the commercial, right? Build it and they will come. So that's exactly what we're up to. And I know that with the new midwifery program, they're so inspiring. They're probably 5 years ahead of us in an implementation, but just understanding that when there's political will, right, you can really gather the support that you need. And I think that we're kind of in this wonderful place, where we can all work together. We have a primary care crisis, and we have shortages, and we know that midwifery really can create that space to provide the care people are wanting, right? And we joke, but we're cheeky about it, but in a sense, don't worry, we will save 10% of our seats for non-Indigenous students to come and join our program. So all Nova Scotians will benefit. But you can go ahead, CJ.
Thank you, Alicia. Thank you to all our speakers. You've provided such excellent info, and I'm excited to move into the small groups and hear people's questions and have some discussion.